We have a very interesting array of topics and speakers for us this morning, and so we are going to get straight into it so that there is plenty of time for discussion after the session as well. So our first talk today is by Rachel Kubayek, and she'll be talking to us about clinic-based urinary LAM as a biomarker of clinical disease, tuberculosis, bacillary burden, and mortality among ART-naive HIV-infected adults.
So I'll be talking about urine LAM, and I'll start with a little background on it. It's a major lipopolysaccharide in the cell wall of Mycobacterium, including of tuberculosis. You can see it's these blue circles here and here, the dark and light blue ones. So you can see it forms a major part of the cell wall. It's released from metabolically active or degraded bacteria and secreted from alveolar macrophages that are part of the body's initial immune response to TB. We can detect it in serum and urine of people with active TB disease, and that's available as an inexpensive point-of-care assay. However, it has a low sensitivity but high specificity, meaning it doesn't detect a whole lot of cases, but we can be confident in the cases that it does find that they're really TB. So our main research question was, does urine LAM screening at HIV diagnosis identify adults with a high TB bacillary burden or greater risk of mortality? We analyzed data from 726 untreated ART-naive HIV-infected adults enrolled from 4 clinics, outpatient clinics in Durban. The nurses performed urine LAM testing and graded positive results from 1, that's exciting, to 5, which you can see on the card up here. They asked about TB-related symptoms and obtained sputum for TB smear and culture, and followed participants for 12 months to assess mortality. We used multivariable Cox proportional hazard models to assess all-cause mortality. You can see that our study population was about half male. They had a low CD4 count with a median of 205. 13% were LAM positive, 19% were smear positive or culture positive. 16% started TB therapy, and 12% died over the course of the 12 months of follow-up. So here we looked at the relationship between different screening and testing tools and mortality over 12 months. And you can see that having a cough or any TB-related symptom was associated with an increased risk of mortality. There was no association between smear positivity and death. But the strongest association and the highest risk was between LAM positivity and death, regardless of how we defined LAM positivity as either 1+ or 2+. There was a 3-fold increase in death over 12 months. And again, all of our models are adjusted for age, sex, education, and smoking status. So here we looked at people with different statuses of TB. So we used as a reference category people with no evidence of TB and who were LAM negative. And we compared these people to people who had sputum confirmed TB or empirically diagnosed TB but were LAM negative, and there was no difference in death. But among those who were LAM positive, there was again a more than 3-fold increase in mortality over the 12 months. And when we looked only at people who had microbiologically confirmed TB, there was again about a 3-fold increase in mortality over 12 months. So the results were pretty consistent. These figures show the rate of death over 12 months of the study. The line in blue are people who are TB negative on smear or culture and LAM negative, so they don't have TB. The red line are people whose sputum tested positive for TB but were LAM negative, and the green line are people who are LAM positive. And you can see that the proportion of people who died and the rate of death was much higher among people who were LAM positive compared to the other two groups. Now we know that urine LAM is associated with a low CD4 count, so we wanted to see if this was simply an artifact of identifying the people who were the sickest with a low CD4 count. So when we looked at only people with a CD4 less than 200, we found that the effect persisted, and people who were urine LAM positive still died at a faster rate, and a higher proportion died. So in conclusion, among these HIV positive results, clinic-based urinary LAM screening identified TB-infected adults with a threefold greater risk of death. We know that LAM is insensitive as a standalone screening test, but we think that it could accelerate initiation of anti-TB therapy, especially among those who are at greatest risk of this poor outcome. Currently, the urine LAM assay has advantages over sputum-based testing, namely that it's cheaper, it's relatively cheap, it's easy to do, and collection of urine is safer than collection of sputum and easier to do as well. We think that it's reasonable to follow the WHO recommendations to implement urine LAM screening where it's recommended in these high HIV burden settings. And finally, we think that LAM may have potential use at the clinical point of care to reduce TB transmission and mortality in TB endemic regions. Thank you.
Who is going to talk to us about subclinical tuberculosis among HIV positive adults?
All right, thank you. Good morning. So tuberculosis can be modeled as a spectrum of disease that starts initially with exposure, of course, that then can progress to the establishment of latent infection. And then in the setting of weakened host innate and adaptive immune responses, as occurs in HIV, for instance, can lead to mycobacterial replication, host damage, and progression through first a subclinical or asymptomatic phase of TB, and then with sufficient bacterial burden, mycobacterial burden, and host damage, then the development of symptoms and active TB. But I think this is a really interesting space, this subclinical TB, which was the focus of this study. So our objective was to describe the prevalence, the clinical characteristics, and the risk of mortality for HIV-infected adults with subclinical TB. The work was done in a cohort of HIV-infected adults who were not on any retroviral therapy. This is the same cohort that Rachel just presented, who are presenting for initial care in 4 different outpatient clinics in Durban, South Africa. Everyone at the outset was screened for TB-related symptoms, cough, fever, night sweats, weight loss, and had sputum tested for AFB, smear, and culture. Everyone was started on antiretroviral therapy, and this is how we defined our categories. The main distinction being between those with active and subclinical TB based on whether or not they had any TB symptom or no TB symptoms, but in both cases, everyone had evidence of mycobacterial infection on smear or culture. Treatment was decided by the treating physician, but in general, everyone who had active TB was started on anti-tuberculous therapy, and most folks where the data was available who had subclinical TB were also started on therapy. We evaluated the association between TB disease category and survival using Cox regression 12 months following enrollment and adjusting for age, sex, and baseline CD4. You can see here across the top the 3 different groups. The largest group was comprised of those without TB, so 490 individuals, followed by 106, or 16% of the total cohort with active TB, and then a not insubstantial number, 34 or 5% with subclinical TB. In comparing some of the parameters, mean age was the same across groups. There was a predilection for male gender among those with active TB compared to the other groups. And I'd like to point out differences, first of all, in mean CD4 count. So you had the lowest mean in the active TB group, the highest in the no TB group, and then an intermediate or about mean of 200 in the subclinical group, and that was different. And then there was also a difference in terms of AFB smear positivity, with actually those with subclinical TB having a higher portion being smear positive, 41%, and only about half of that in comparison in the active TB group. Other parameters, AFB culture positivity, prior TB treatment, and tobacco were similar across groups. And I can answer your question now in terms of the symptoms and LAM positivity. I don't present these data here, but in the active TB group, about 33% were LAM positive. In the subclinical group, 26% were positive. And then in the no TB group, about 10% were positive. And that was statistically significantly different across groups. So in terms of the Kaplan-Meier survival curve, it's no surprise that in blue you have the active TB group, worst survival outcomes, but then a similar pattern with the subclinical and active TB folks. Looking at the Cox regression, you have two comparisons here. One is the active versus no TB, and then the second is the subclinical versus no TB. And the adjusted hazard ratios, though both cross 1, I would suggest that there is possible association, though not significant, with mortality in the active group, but no difference in terms of mortality in the subclinical comparison. So to conclude, subclinical disease was seen in 5% of our cohort of HIV-infected adults. In other terms, about a quarter of all microbiologic TB was subclinical TB. There were no significant differences in survival, although our small sample sizes did limit our power to detect such a difference.
3 minutes.
There was an intermediate degree of immunosuppression, as well as greater sputum smear positivity, that though there are variable findings in the literature with regard to bacillary burden in these groups, I do think has important implications for preventing TB transmission. Thank you.
It's going to be a slight change for those who wants to ask a question for the recording of the session. Please, let's use this microphone.
So that's really quite interesting data. Would you suggest, I mean, it seems to me that what you don't know is if you hadn't treated, if you hadn't sent the sputums for smear and culture in the asymptomatics and had not treated them, the mortality rates obviously would have been way worse. So would you think that perhaps, I mean, we've always been worried about this screening algorithm missing tons of TB, that perhaps we should be screening more aggressively regardless of symptoms? Because you obviously, I mean, it looks to me like you saved lives, which would not have happened if we hadn't screened for the asymptomatics.
I agree. That's an absolutely excellent point. You know, the study that, the theoretic study would be to see what outcomes would have been in the absence of for-drug therapy. Although it's, I think, hard to argue that to any clinician, of which I am, you know, that if you have active replicating bacteria to do that. You know, in terms of screening, it's hard to screen everyone, and there may need to be a targeted approach in terms of limited resources. Certainly, HIV-infected ART naive would be that one of the high-risk populations that I would advocate for if resources were available. I mean, ultimately, if we had a diagnostic test that could tell us that was cheaper than doing smears and cultures, that would be the best situation.
No, I just wanted to comment on that. The comment was that if these patients had not had triple therapy, the mortality rate would have gone sky high. I want to challenge that dogma. I don't personally think that's likely to be the case. I think in my hunch, and there isn't no data, and I'd like to do the study, is that these patients do absolutely fine on isoniazid and antiretroviral therapy, and they have a low bacillary burden. Some of them are just transiently culture positive anyway. Some of them would probably do fine on antiretroviral therapy alone. You add in IPT, these people probably do fine. And the WHO algorithm, although it's missing these people, and although there's this concern that it's missing these culture-positive people, I suggest that it's probably not as bad as everybody makes out.
I think there are arguments to be made in support and against the point that you make. One is that in some of the observational studies, when people have been incidentally found, they oftentimes have been on IPT because they were ruled out for active TB. And yes, they did do fine and they didn't develop drug-resistant TB, et cetera. On the other hand, a number of these individuals are going on to develop active TB within a few days to a few weeks. And so That's a tricky scenario because, that's a situation where mortality does really bump up to the active TB group. So I think there are arguments to be made on both sides. What the answer is, I don't know.
So the one rebuttal I might have to that, Tom, and what I was surprised by is the high percentage of AFB positives in the subclinical group. What we've seen in very small numbers is they're more likely to be culture positive than AFB positive. And I think if they're AFB positive, that suggests far more disease that's further down the line than just a culture positive that is sometimes transient in our experience as well. I don't know if you have anything to add to that.
When you look at the studies, again, similar small numbers, there are studies where there's more bacillary burden in the active TB group versus subclinical. I don't know what the overall pattern will shake out to be once we have larger studies. But the other thing to keep in mind is the implications for transmission, not just what happens to the individual patient in terms of their mortality and morbidity.
Thank you so much.
Elena Huerga, presenting on the value of determining TB LAM test as screening test and diagnostic tool for tuberculosis diagnosis in HIV adults.
Thank you. Good afternoon. So you have had already a background on this test, on the LAM test. Just to highlight the main points, this is a point-of-care test that uses urine samples, produce very fast results in 25 minutes, and it's only useful in HIV-positive patients that are immunocompromised. So as the previous presenter has said, this test has a sensitivity of around 50% in adults and a high specificity. So in our study, we assessed the value of LAM test as a screening test, ruling test, and as a diagnostic tool for HIV-positive patients in programmatic conditions in Malawi and in Mozambique. So this was a prospective cohort study. We included HIV-positive patients in programmatic conditions. We had 3 cohorts of patients. The first cohort of patients, we used a LAM test as a ruling screening test. The patients were ambulatory. We performed the test regardless of the presenting symptoms, and these patients had a CD4 count of less than 100. Patients were recruited in Mozambique. Cohort number 2, where the test was used again as a ruling screening test in hospitalized patients, regardless of the presenting symptoms and regardless of the CD4. And this was in Malawi. And cohort number 3, the test was used as a diagnostic tool in ambulatory patients that were presenting with TB symptoms that had a CD4 count less than 200, and this cohort was recruited in Mozambique. So we requested expert systematically for cohort number 2 and 3, so hospitalized patients and patients with TB symptoms. And we assessed mortality at 6 months. So here are the results. You can see that the CD4 count, the median CD4 count varies according to the cohort. In the first column, you have cohort number 1, ambulatory patients regardless of TB symptoms. Cohort number 2 is column 2, hospitalized patients. And cohort 3 is column 3, ambulatory patients with TB symptoms. So the inclusion criteria of regarding the CD4 varied in the 3 cohorts, so the median CD4 varied according to that. So regarding the request of expert tests for hospitalized patients and ambulatory TB patients, patients with TB symptoms, we requested this test, and so we asked patients to produce a sputum samples, but as you can see, half of the hospitalized patients were not able to produce this sample, and 20% of the ambulatory patients presenting with symptoms were not able to produce a sample. So expert was positive in 9% of all hospitalized patients and in 19% of the ambulatory patients presenting with symptoms. And LAM test was positive in 12% of the ambulatory patients with low CD4, less than 100, that were not presenting specific symptoms, in 22% of the hospitalized patients that were also screening regardless of symptoms and CD4, and in 45% of the ambulatory patients that were presenting with TB symptoms. And the difference between this LAM positivity and the expert positivity in patients hospitalized and with symptoms is mainly due to the fact that a number of patients could not produce a sputum. So 55% of the patients that had a LAM positive test, we did not have an expert result for them, and 22% of the patients who had a LAM positive test, we did not have an expert result for them. All patients that were LAM positive were treated on the first consultation because we had the LAM result immediately. We look at mortality at 6 months. Mortality varies according to the cohort. As expected, is higher among hospitalized patients. And we look at the association between LAM positivity and mortality, and we found that LAM positivity was associated with a higher mortality in the patients that were ambulatory, where the test was used as rule-in, and in hospitalized patients, where the test was also used as a rule-in. So in conclusion, LAM as a screening tool for regardless of TB symptoms was useful to detect TB in a considerably proportion of HIV-positive patients, both among ambulatory with very low CD4 and among hospitalized regardless of the CD4. And it also allows to identify patients at higher risk of mortality in these populations. And LAM as a diagnostic tool in symptomatic patients with less than 200 CD4 could diagnose rapidly a high proportion of patients and allow treatment rapidly in these patients. That part of them will have been missed using a sputum-based diagnostic tool. Thank you very much.
I just wanted to know what could be the differences in characteristics between the first column and the third column in terms of the LAM positivity. It seemed like there was a marked difference. Are you able to explain?
Yeah, the first column was patients that had less than 100 CD4 but did not have any symptom. So these were patients that were seen in a normal ART HIV clinic that was a referral clinic for very sick patients with less than 100 CD4, but did not present TB symptoms. So was used as a rule-in screening test in patients without symptoms. That's why we found 12%, which is already relatively high for this population that is not presenting symptoms. The third column was patients who had TB symptoms, were coughing, etc. So these patients, again, it's quite high proportion of LAM positive, but these patients had symptoms, were ambulatory, had less than 200 C4, but had also presenting with TB symptoms.
And he is, in keeping with the theme, going to talk about diagnostic accuracy, incremental yield, and the cost of determined TB and sputum induction. Thank you, Tom.
Thanks very much, and thanks for the opportunity to speak. So yes, I'm going to continue discussion about LAM and sputum induction in seriously ill patients. And those are my collaborators. So to put it in context, this is what we're talking about, very sick patients, not patients walking into clinic. This is done in Cape Town, South Africa, in 2 secondary hospitals, patients with advanced HIV in general, and with danger signs and cough. And when this study was conceived, this was the WHO algorithm for speeding up diagnosis and improving outcome in patients. This was from 2007. The entry criteria, as you can see, was cough for 2 to 3 weeks, plus danger signs, and the algorithm used largely smear microscopy and response to antibiotics. And this cohort study was designed to try and improve on this algorithm and validate it to some extent. And because 2 to 3 weeks of cough was never really a very good rule-in test for TB, this study used any duration of cough plus danger signs as the entry criteria. By the time the study had been completed, you may have missed this, but this was published just under a year ago. The WHO had upgraded the algorithm, and they'd taken away cough completely. So the entry criteria now are just HIV positive, seriously ill, and danger signs. And this algorithm relies heavily on expert MTB-RIF. And if you look really carefully, there's a tiny little asterisk saying you may consider possibly thinking about using urinary LAM, but doesn't rely on it heavily. So what happened in this study was these adult patients with HIV any duration of cough, and WHO danger signs were enrolled into a prospective cohort, and they had a battery of tests performed on them. They had urine that was stored and urinary lamb, and for those who asked before, we used a cutoff of 2+, read by 2 independent observers, because the 1+ category loses specificity quite dramatically. Patients were asked to provide spontaneous sputum, and when they couldn't do that, nebulization was used, and they had nebulized sputum. Sputum was sent for expert MTB RIF and culture. They also had a TB blood culture, and they had culture of various other body fluids as appropriate, ascites, pleural fluid, whatever, during their admission. And then we looked at the results, and there were 325 patients in this part of the cohort, and the TB prevalence was high. 50% had TB, and to categorize TB, it was culture from any body fluid. Sputum, blood, pleural fluid, anything that was positive was a diagnosis of TB. And what we did was we modeled how the use of these tests might be used in an algorithm when you do one test after the other. So you do a test first, and if it's positive, you start treatment, and if it's negative, you move on to the next test amongst these 325 patients. And so this is what it looks like just using expert MTB RIF. So the large circle is all the patients with TB, and then there would be a larger circle of all people with not TB. So if you just do spot expert, that is expert on spontaneously produced sputum, you'd pick up 39 of the 169, so a pretty poor pickup rate. If you then, those who couldn't produce sputum, you moved on to do sputum induction and expert on that, the increased yield was dramatic, went up to picking up 153 of the 169 patients. If you then went on to do a single culture on all those patients who were negative, then you can see there's a tiny rim there, a slightly increased pickup. And then there were a few patients who wouldn't be picked up by any of those, and they were picked up by something like a TB blood culture or a pleural fluid or something. We then modeled what would happen if you introduced LAM, and you did LAM first on everybody. That's on 325 patients. Those who were positive, you went on to treatment, and those who were negative, you went on to look at their sputum, and this is what we found. So 60 patients with TB were LAM positive. And then similarly, a spot sputum had a very relatively small yield, but doing induced sputum and an expert increased the yield dramatically, such that you got almost all the patients. So if you compare those two, you can see that an algorithm with and without LAM has a very similar yield if you've got sputum induction available. But we know, and we've heard already today, and we know from other studies, that LAM has other advantages. Firstly, it's highly sensitive for very sick patients who need treatment. Secondly, it's a true point-of-care test, unlike expert. But we also looked at the costs. And if you look at the cost per patient, just in terms of tests, and this means testing all 300 patients for each test in series, then the cost of tests not using LAM was $50 per patient. But if you throw in LAM, the cost reduced to $42 per patient. So although when sputum induction is available, LAM doesn't increase the yield of diagnosis, it does have other advantages and decreased costs. So on the basis of this, we've suggested an update to the WHO algorithm with the same entry criteria. Rather than having LAM as an asterisk, we think LAM should be right up front. That all patients, for various benefits we've discussed, should have a urinary LAM and a chest X-ray. Those who are LAM positive should go straight onto treatment, although we must continue to consider other diagnoses, because many of our patients had dual diagnoses, including PCP and CAP. Those who are LAM negative, again, we should consider other diagnoses, but we would suggest going on to an expert ultra, because ultra is, despite some of the caveats of specificity, is going to be rolled out. And that, in fact, sputum induction was extremely important to increase the yield. And we suggest, based on this, that if you're negative for both LAM and induced sputum ultra, that your chance of pulmonary TB is extremely low, and the increased pickup from a culture is very small and unlikely to be cost effective. And in fact, we should be looking in those patients for other diagnoses, including extrapulmonary TB and other pulmonary diseases like CAP and PCP. Thanks very much. Those are the conclusions.
Are there any questions for Tom? Any questions? No? Anything else? Great. Right. He's going to shift our focus a little to TB screening and IPT.
Okay, good morning, and thanks for the opportunity to make this presentation. So I'll be talking about TB screening practices as well as the preventive therapy among people living with HIV in Kenya before and after initiation of ART. WHO recommends isoniazid TB screening, intensified TB case finding, isoniazid preventive therapy, and isoniazid preventive therapy for those without tuberculosis. In our study, we reviewed medical records from a national representative longitudinal cohort for HIV infected patients who are enrolled in care. Those were adults aged 15 years and above who were enrolled in care and had not had any exposure to ART. So our aim was to review the TB screening practices, TB incidence, and provision of isoniazid preventive therapy. Looking at this slide, we examined service provision from the number, that's from visit perspective, and overall we had a total of 3,100 patients enrolled in the study, of which 66% were females. So 66% were females, and the median age was 34 years. Overall, there was about 58,000 visits in all, and of these visits, 71% had a documented TB screen. TB symptoms were present in 2% of those, and smear or gene expert test was done in 23% of those who had symptoms. Among those who had a gene expert or smear, 6% had a positive test, 53% had a negative test, and 41% did not have documentation of any tests, suggesting a documentation gap in that group. Now, if you look at the same data from a patient perspective, we find that 68% of patients were screened on the last visit. 13% had symptoms coming from any visit, screening during any visits. And of those who had symptoms, 37% had a smear microscopy test. Chest X-ray was done for 22%, and gene expert test was done for only 3%. Looking at a combination of these investigations, 47% had either at least one or more of the investigations done to try to establish whether they had tuberculosis or not. So TB, overall, we had TB about 27% of patients who had investigations having been found to have TB, and this yield is quite high compared to what we expect. And then TB being diagnosed without documentation of any investigation or screening was identified among 144 patients. That's about 4% of the overall cohort. Looking at the distribution of TB cases diagnosed in the space of time, we found that majority of TB cases were diagnosed within the first 1 year. About half of the TB cases were diagnosed within the first 1 year. Again, looking at it from the IPT perspective, we found that 92% of patients ever screened negative, had no symptom during screening. 99% were eligible for IPT, meaning that they had negative symptom screen and they were not continuing TB treatment at the time of screening. And then those who had negative TB symptom screens and were eligible, only 29% were evaluated for IPT, and of those, 38% initiated IPT. So we followed this cohort to determine what proportion of those who were eligible for IPT had TB, and either having been initiated or not initiated, and we found that 0.3% of those who were initiated IPT came down with TB compared to 4% among those who were eligible and did not get IPT. Now, with regard to timing of IPT initiation relative to the eligibility, we found that most of the patients were initiating IPT, about half of the patients were initiating more than 3 years after the first time they were eligible for IPT, suggesting a delay and a missed opportunity, given that majority of the patients develop TB in the first 1 year after enrollment in care, while majority get IPT much later. So in summary, this cohort reflects patients who were initiated enroll in HIV care quite a while back, that is from early 2000 to 2013. There's a lot of changes that have occurred in Kenya with the scale-up of IPT. Screening practices have improved quite a bit. And we really need to ensure that even while we know that this does not represent the current practice, we need to ensure that IPT among the patients that we're enrolling currently is initiated early enough, given that most of the incident TB cases will occur early. We need to consider having future assessment for prospective cohorts to establish the current practice. Thank you.
Hi, that was a fantastic presentation, and just seeing the huge number of people who've initiated IPT in Kenya is quite amazing. I'm wondering, do you know with your data, Kenya is one of the few countries that's rolling out IPT in pregnant and postpartum women, and I'm wondering, do you have any idea of how many of these individuals might have been pregnant or postpartum? It's kind of a niche question, but...
Hello, good morning. Thank you for your wonderful presentation.
Okay. Fine. Okay. I think currently we have about 80% of all people living with HIV in Kenya having been initiated on IPT, and this includes pregnant women. We try to review program data for CDC-supported programs, and I think close to HIV pregnant women and breastfeeding women who are HIV positive, I think about 60% of those get IPT. But I think one of the gaps that we've identified is that we have some of these women transferring from the HIV care clinic to the MCH clinic, having had IPT, but this information is not documented in their MCH clinic. So I guess the proportion is much higher than what we anticipate. Yes. Yeah.
Okay, thank you. For those who were diagnosed with TB, did you try to find out how many were linked to TB treatment? Because I know sometimes we have a problem with diagnosed patients in the IPT program, but linking them to TB treatment is a problem. What proportion of those who had TB were started on TB treatment?
Okay, we did not look at that, and probably I think we may want to check that with the data that we have. This was only preliminary analysis of the cohort data. But I think if you identified, majority of our patients actually get linked to TB treatment clinics, because I think close to 80% of our HIV and TB clinics are integrated. But that said, we also have an inventory study that indicated that close to 20% of TB patients in the country are not linked to treatment, and we are trying to close these gaps.
Thank you for the wonderful presentation. I just have one question. In this study, you found a significant delay in provision of IPT. What could be some of the reasons that led to this significant delay?
Okay, this cohort goes back to 2003. Patients enrolled in care in 2003, yet we started scaling up IPT in 2015 properly for the entire country. So we find that between 2003 and 2014, 15, we only had pilot projects. And if you combine patients in areas where IPT was not routinely done over a long period of time, we may find that that may influence quite a bit. But again, I think one of the issues that we are concerned about that has to do with our guideline is the fact that we are trying to initiate patients on IPT who are more likely to adhere, patients who had recorded good adherence on ART. And I think that is potentially a downside of it, because before we ascertain that a patient is adherent, it takes quite a bit of time having them on cotrimoxazole preventive therapy. We may want to review this and ensure that we have better ways of assessing patients for adherence for them to have early IPT.
Thanks for the good presentation. I've been working in 4 high-burden countries, South Africa, Namibia, and Botswana. High-burden TB and HIV with a lot of co-infection, and we've been pushed to do IPT. I'm not a believer in IPT, sorry. I've just got a question for the audience. For us who work with TB and HIV patients, how many of you have noticed patients who, when you ask them for your next visit, the patient is no, I'll be at the clinic taking my TB meds. But if you look in the clinical chart, the patient is actually being screened for TB for the last 3 months, and they say no symptoms of TB. And how many of you have had patients, maybe on Alluvia, who are taking rifampicin from the clinic, and you're giving them Alluvia, and they end up failing the Alluvia, and you have to put them on 3rd line. So I still am not a believer in IPT, because I don't think the screening is being done well. That's one thing. But I think it's for the audience, not for you, sorry.
Thank you very much for the comment. Perhaps we're going to leave those discussions for after the session for small groups. Thank you.
But that's great. Alexander K is going to be keeping in the theme of IPT, but talking about pediatric IPT.
Thanks, everybody. Sorry. So today I'll be talking about pediatric isoniazid preventative therapy in HIV-positive patients at the Baylor Center of Excellence in Baban, Swaziland. So to provide a bit of background, in Swaziland, 6 months of IPT is recommended every 2 to 3 years for children living with HIV. There's little longitudinal data on how IPT impacts ARV adherence in children, and that's a major concern among many of the pediatric HIV providers in Swaziland. We asked the following questions. Are certain pediatric patients less or more likely to receive IPT? What's the effect of IPT on ARV adherence? And what risk factors exist for developing TB after IPT in our pediatric population? So we performed a retrospective cohort review of HIV-positive children 0 to 18 years enrolled in care at Baylor, Swaziland using electronic medical record. These children were enrolled in care between 2006 and 2016. Baylor, Swaziland is a pediatric HIV/TB clinic caring for approximately 20% of Swaziland's children and adolescents living with HIV. So to get our first question, we looked at a total cohort of 1,778 children. We found that overall 58% had been placed on IPT and 42% had not. On multivariate analysis with adjusted odds ratios, we found that young age, less than 5 years, was associated with an increased likelihood of being placed on IPT, whereas adolescents were less likely to be placed on IPT, perhaps because of providers' awareness of the increased risk for severe TB disease in young children and challenges with adherence in the adolescent population. Prior TB treatment, interestingly, was associated with a decreased likelihood of being placed on IPT. There may have been a sense of security that we've treated TB, that's not an issue anymore. However, I think that these children are probably at more risk for ongoing exposure to TB in the future and would likely benefit from IPT courses. CD4 count, low CD4 count was associated with an increased likelihood of being placed on IPT. Again, I think probably an increased perception of risk in that population. And ARV adherence, less than 95%, was associated with a decreased likelihood of being placed on IPT. And this gets to one of the main points of this talk, which is providers are concerned about adding IPT to a child or adolescent that's struggling already with maintaining good adherence on ARVs. We do have children that you'll see at the bottom with an adherence of greater than 105%. That's because our adherence numbers are based on pill counts, which is absolutely an imperfect measure of adherence, but it's what we use at the clinic. And oftentimes we'll see an adherence of greater than 105% in the case of losing some of the medications and or dumping medications prior to arrival in order to avoid lengthy conversations about adherence. So what is the effect of IPT on ARV adherence in this population? We looked at a subset of the total cohort, 586 children who had very good adherence data for 1 year prior to IPT for their ARVs, and then adherence data for their ARVs during IPT. We found that ARV adherence decreased by 0.5%, which was statistically significant during IPT, but we did not feel that this was a clinically relevant change in any way. Then we subsetted to children that were struggling with IPT or with ARV adherence prior to initiating IPT. We found that in those children with less than 95% adherence to ARVs, they actually improved their adherence by 4% when they were placed on IPT. So even in this population that was struggling, they didn't have more problems secondary to the addition of another medication. And lastly, we looked at a smaller subset of children that were initiated on IPT prior to 2012 in order to give them time to develop incident TB. In this population, we had 305 children, 64 had TB, 204 did not have TB. We identified 2 associations with an increased likelihood for TB development despite IPT. That included the time on ARVs prior to IPT, so children that were not on ARVs when they received their first course of IPT had an increased likelihood of developing TB following their IPT course, and children with a CD4 count of less than 500 and particularly less than 200 had an increased likelihood of developing TB following an IPT course. So to conclude, we found that IPT did not have a significant impact on ARV adherence in our cohort. This was reassuring to myself and a number of the other providers. We found that there was an increased risk for TB after IPT in children that had not had ARVs prior to IPT and had a low CD4 count, and we wonder if further work could be done looking at this group or others like this group in particular to see if an extended course of IPT might be beneficial for these children. Then we also identified some children that were at increased risk or less likely to receive IPT, those with a history of prior TB, those age 14 or 15 to 17 years of age, and those with poor ART adherence, and we think that population might be those populations might also benefit from IPT and should be the subject of training with providers around the country, that these populations can also benefit from IPT as well as the ones that we're aware of that are extremely high risk for TB. Thanks so much.
Thank you, Alex. It always takes a moment. I find it very interesting that that clinicians may potentially not be giving IPT to people that are anxious about their adherence on ARVs. My colleague Catherine Orrell has repeatedly shown that clinicians are terrible at predicting who's going to be adherent and who isn't. And so your finding of the improved adherence when you add IPT, I think, is very interesting. I don't know if there's anything you want to add to that.
No, not really, except that yeah, I totally agree with you, and this was a long-standing perception, and I think it's a common one, and it was really interesting to have this data and actually be able to say, you know, look, no matter what we think, this is actually what's happening for these kids when they're placed on IPT.
This question is slightly tangential to your presentation, but a common concern is the development of resistance amongst those that eventually develop TB. I wonder if you have any comments regarding the DST patterns of those who eventually develop TB afterwards.
Yeah, I mean, that's a great question. This cohort isn't really an ideal one to look at that because we have DST results and culture results on so few patients in this cohort. A lot of these children were treated for TB on a presumptive kind of clinical basis. So I haven't looked at that in particular, but it's a good question, something that we could go back to.
Lou Koye, who is going to be presenting on the high HIV prevalence among presumptive tuberculosis patients.
Yes, I'm presenting some implementation that we do in Kampala. Kampala is the capital city of Uganda, about HIV testing among presumptive TB patients in this city. So WHO recommends HIV screening among all presumptive TB patients, and this is because it is feasible and offers potential for early HIV diagnosis and treatment. And the HIV prevalence rates among PTPs has been documented in various settings, but and it differs. So within this analysis, we tried to establish the HIV testing rates among presumed TB patients, the HIV prevalence among this category of patients, and then linkage of the diagnosed patients to care. So what we did was a records review of the presumptive TB registers. Within the TB register, we have a column for HIV testing, and the period we covered was January to June 2016, and we collected data on total number of presumptive TB patients identified, the number tested for HIV, and the linkage of diagnosed TB patients to HIV care services. But we also tried because it is TB is the entry point, we also tried to establish the TB among this category of patients. So in total, we had 9,129 records that we reviewed for this period, and we found 92% of these patients were actually tested for HIV, and we found that despite the fact that the entry point is TB, we found 53% of these PTPs actually HIV co-infected. 88% of these patients were found were linked to care, and now we found 15% of this category still having TB. And surprisingly, we realized that about 40% of these patients did not have a documented TB status in this presumptive TB register, much as many of them actually had HIV results. So in conclusion, we conclude that the prevalence of HIV among presumptive TB patients in Kampala is very high. And when you compare this one to the national prevalence among TB patients, we found the TB HIV co-infection at national level is around 45% overall when you take Uganda as a country. And HIV prevalence at population level is around 6.4%. But here among PTPs in Kampala, it is around 53%, which is high. But also notice that at least much as they are not yet confirmed with the TB, linkage of these patients to care is good. Around 88% of these patients actually linked. And then we also noticed significant documentation gaps in these registers, since most of them had actually HIV results, and a significant proportion, around 40%, never had TB testing results in the presumptive TB registers. So we recommend HIV testing levels among presumptive TB patients as a way of early diagnosis of HIV and the linkage of these patients to care, much as they come in with TB symptoms to our facilities. Thank you very much.
Thank you so much. Maybe I could ask, well, firstly, congratulations on your very high HIV testing rates among your presumed TB patients. I think the poor documentation, the follow-through of completing the registers is not an uncommon problem. Do you have ideas of how you might tackle that now that you've recognized the issue?
Yes. Usually what happens at facility level is that patients are taken very seriously after they have been diagnosed as having TB. And at that point in time, the documentation, the TB register, Unity register is very nice. But before they are confirmed as TB patients, and the documentation, the presumptive TB register remains a problem. That one also goes to, of course, screening, which has been a long-standing problem that not everybody sometimes is screened. But still, after screening is done and probably testing has been done in the laboratory, the documentation of those results, since they are not confirmed to have TB, is usually a problem. So they take other directions and they never end up in this presumptive register to document whether they are actually having TB or they are not having TB.
Thank you very much. A descriptive analysis of the PEPFAR TB HIV portfolio. Thanks.
Excellent. Good morning. I'm Catherine Nichols, and I'm going to present research that was conducted by myself and my colleague Katya Nojkovic, who's sitting here in the second row in the front. So I'm going to present on a descriptive analysis of PEPFAR's TB HIV portfolio. So first, just want to acknowledge the work of the PEPFAR country team. So PEPFAR, which stands for the U.S. President's Emergency Plan for AIDS Relief. So the data is reflected from these country teams in this presentation. We'd also like to thank our PEPFAR headquarters colleagues for reviewing our research, and also our colleagues at the Interagency Collaborative for Program Improvement, which is a group of PEPFAR data analysts that sit in Washington, D.C. So I think, as we all know, so TB is the #1 killer of people living with HIV. So the U.S. President's Emergency Plan for AIDS Relief is committed to reducing comorbidity and mortality related to HIV-associated tuberculosis. And so what we're going to look at today is 2 specific indicators, one around TB patients who know their HIV status, and also around TB patients who are HIV positive who are on ART. So we're going to be looking closely at those 2 indicators. And so our attempt here is to describe the PEPFAR TB HIV portfolio in this capacity, again, on the TB patient side in East and Southern Africa, and highlight recent successes and challenges. So again, this is a descriptive analysis on documented client interactions collected at PEPFAR-supported sites between October 2015 and September 2016, so that's fiscal year 2016, from 16 countries in East and Southern Africa. So again, this is monitoring and evaluation data, so we're looking at a very, very high-level snapshot here today, but looking mainly at the percentage of TB cases with a known HIV status, as I said before, percentage of TB cases with a known HIV status who are HIV positive, and then also looking at the percentage of HIV positive TB cases on antiretroviral therapy. So looking at this first slide of results, which we've situated by region. So if you take a look at this big graph here, on the left side there in blue, so we have East African countries. So again, this is aggregated data, but looking in general at the percentage of TB cases with known HIV status, which for East African countries, again, this is PEPFAR supported, that percentage is 89%, versus Southern Africa countries, which is 95% there. So Southern Africa being higher. And then if you look at the far right side of this slide, I want to call your attention to the percentage of HIV positive TB cases on ART, so those who are started. And again, we're seeing the reverse trend here in the East African countries. That value is higher at 91% and versus 83% in the Southern African countries. And so, of course, the sort of threshold that we're looking for here for success is 100%. And then I wanted to show this as well, so the results by country. So this is a very busy slide, but just to say in general, speaking to the color coding here, so again, looking at a threshold. So what we've done is assign colors here. So anything in blue is 90% or above, and there's a gradient as a darker blue as you get closer to 100%. Versus those that we've highlighted in red, which is anything less than 90%, which might indicate that we need further analysis. And so what I want to point out here, though, is in general, again, there's a lot of numbers here because we're using these raw numbers to get these percentages. But the main takeaways here, so on the left side of this slide, so you'll see the indicator for the registered new and relapsed TB cases with a documented HIV status. You can see in general that there are less reds here, so we're seeing closer achievement towards 100%, which is a little bit different on the right-hand side when we're looking at HIV positive new and relapsed registered TB cases on ART. So there are more reds there, so indicating that we want to do further work to get closer to 100%. So again, this is at the country level here, and it's organized by East Africa, there on the left-hand side, and then Southern Africa. So our conclusions and key recommendations. So again, this is a very high-level snapshot of, hopefully answering the question of what is going on in terms of PEPFAR-supported programs on the TB patient, TB clinic side. So in general, we are seeing very good progress. Again, we want to do more to get towards that threshold of 100%, and in particular, a focus perhaps on getting those folks who are TB patients who are HIV positive, making sure that they are being linked to the ART side and that ART coverage is increased. And so again, I think the last point here, just making sure that if we're looking at these two indicators, we're striving to achieve 100% coverage for these important services.
Hi, I'm Bill Coggin with CDC, and Catherine, thank you for that great presentation. I think this really highlights what has been known for several years, that the TB entry points have been very successful in testing patients and delivering them to HIV care. The one point I think we have to keep in mind, however, is considering the low case notification rates and the missing TB cases who are not availed of the HIV test nor the opportunity to get into HIV care. So when we see the above 90s, we have to consider where are the missing cases who still need to be diagnosed and have access to those services.
Thank you for that.
Thank you for the presentation. I'm from Zimbabwe. I think it gives a good snapshot of what is happening. The only concern is, I don't know how valid that snapshot is, because the figures that you portray for Zimbabwe are not the correct ones. So I'm not so sure where you got the information from, but I think we could assist with providing the real data.
Thanks for that comment. So yes, I will say that this is, again, data that is indicated as PEPFAR supported, so that country teams are reporting starting from the site level, and they're being aggregated all the way up to the country level. So I think you're exactly right that a lot of times when we are looking at monitoring and evaluation data, there are a lot of inherent biases that are going on, and so therefore it is difficult, I think, at times to make conclusions. But I welcome discussions on thoughts related specifically to this data and being able to drill down. It is quite amazing within the PEPFAR realm, the amount of data that there is access to when you think about the site level. For example, in Kenya, there's 5,000 PEPFAR supported sites, times several hundred indicators that are being collected. So yes, it gets very complex very quickly, but I welcome discussions on how to improve this data and yeah.
Just a second on the comment that was mentioned before. In Botswana, TB is not just on it. Although PEPFAR focuses primarily on HIV and most of the indicators and efforts are targeted towards HIV, TB is a marker of those patients with HIV that perhaps have fallen out of care and or fallen through the cracks in the system. So the yields of newly diagnosed HIV amongst patients with presumptive TB cases are pretty high, perhaps amongst the highest. So in epidemics that are pretty advanced in terms of their control, near to reach epidemic control, targeting presumptive TB cases or TB cases themselves, it is a quite high yield strategy, an important one.
Hi, thanks for the presentation. My name is Avinash. I work with WHO Global TB Program in Geneva. So my question is related to the colleagues' question from Zimbabwe, that we see impressive numbers for most of the PEPFAR supported countries. The question is this data reflected in the national HMIs when they report globally? Because some of these countries, data may not match with the proportions that you mentioned. So I'm wondering, is it reflected in the national system when they report globally?
Thanks for that question. So, right, to be clear, these are not national numbers. That's right. So they are PEPFAR supported only. So you're right that could be certainly skewing, what's going on if you're trying to look at the overall country level. So in some cases, PEPFAR is supporting a very small percentage of the overall portfolio. So there is variation there, but you're exactly right. These are not national numbers.
Okay. 2 quick questions, please.
Just partly, I'm from Uganda, Raymond, working with TB and USAID funded project. But one of the possible answers is that actually some of these numbers, all numbers are reflected within the national system through the DHIS2 system. So they contribute towards the national figures. They might not be the final, but they contribute towards the national figures. But my quick question was on the cascade from now the HIV side. Are we able to identify the missed cases from the HIV side, the TB cases from the HIV side? And if they are, how are we able to do that? Because many of the PEPFAR programs, as someone said, that they are mainly under HIV, but we usually miss the TB cases from the HIV side. Often we get HIV patients from the TB side, but it's difficult to get them from the other side. So does these programs actually help in terms of getting the missed cases from the HIV side? Thank you.
That's a great question. And yes, I would like to clarify that one thing that I did not show here is exactly what you're talking about. So on the ART patient side, what's going on that side in terms of ART patients who are screened for TB, if they're negative, whether they're actually started on IPT versus being positive, starting on active TB treatment. So you're right, there is actually a lot of information and indicators that are captured on that side, and they are being collected now. And I do think it's a good source to look at. You're right, because in terms of if the standard is that all ART patients are being screened for TB, is that happening routinely? I think it might not be, but it'd be very interesting to look at that level of information. We do have that in the PEPFAR space. Yeah.
Thank you, Catherine.
Thank you.
Thank you. Here's a little again, and Sarah's going to talk to us about pulmonary function before and after ART initiation. Thank you, Sarah.
Thank you. Good morning, almost lunch, everyone. Maybe we can adjust the slides over. But I'll start and say it's increasingly recognized that there's a colliding epidemic of TB, HIV, and chronic obstructive pulmonary disease, or COPD. In the map on the top right here, you can see TB incidence, on the bottom right, COPD deaths, and you can see there's substantial overlap in the areas impacted by these epidemics. Over the next several decades, it's anticipated that COPD is actually going to become the 3rd leading cause of death worldwide, in part due to contributions of TB and HIV to increasing rates of chronic lung disease. Meanwhile, TB, HIV, and co-infection remains a substantial global health challenge, with 11% of new TB cases and 0.4 million TB-related deaths each year among people with HIV. Up to 25% of co-infected patients will develop immune reconstitution inflammatory syndrome, or IRIS, following ART initiation, where they'll have an acute increase in immune activation that's often accompanied by a clinical deterioration. There's concern that this immune activation and TB IRIS in people with HIV and pulmonary TB may actually cause unwanted structural lung damage and contribute to increasing rates of COPD, even amongst individuals who are otherwise cured of their TB. And so we sought to answer the question of whether TB IRIS contributes to lung injury and even COPD among patients starting ART and TB treatment. So for this ongoing study in Johannesburg, South Africa, we're enrolling newly diagnosed HIV-positive adults with expert-positive pulmonary TB who are initiating ART and TB treatment in accordance with South African national guidelines. Study visits are conducted at baseline, which is shortly following TB treatment initiation and near the time of ART initiation, and then at 4, 12, 24, and 48 weeks. We're performing pulmonary spirometry, including measurements of the forced expiratory volume in 1 second, or FEV1, and forced vital capacity, or FVC. We're also performing a 6-minute walk test, where the distance an individual can walk in 6 minutes is measured in meters, and a COPD assessment tool, which is a standardized questionnaire to gauge the severity of COPD symptoms. This table includes patient characteristics at baseline and 4 weeks, and among 60 participants enrolled to date, the median age is 36, 58% are male, and the median body mass index is 19. About a third of participants reported ever smoking. None reported current smoking at the time of study enrollment. Between baseline and 4 weeks, there was an increase in CD4 count and a significant decrease in viral load, corresponding with the initiation of ART. There was no significant change in the distance covered during the 6-minute walk test, but scores on the COPD assessment tool did decline during this period, reflecting a decrease in pulmonary symptoms. Overall, there was no significant change in lung volumes or in the presence of airflow limitation, although at both time points, about 20% of patients did have airflow limitation, which we defined as an FEV1 to FVC ratio of less than 70%, with a FVC greater than 80% of predicted. We next looked at changes in pulmonary function and symptoms over time, and here you can see the changes in FEV1 over time, and generally that they are quite mixed when you look at it on a patient level. But the overlaid spline curve shows that there's a slight dip potentially at the beginning, followed by a rise over the course of treatment. Although I will point out that we have fewer data points at the later time points, and so it's not clear yet if these trends will hold as we gather more data. In looking at the early change in those patients who had data at baseline and 4 weeks, we found that actually about half of patients had an initial decline of greater than 100 milliliters in their FEV1, their forced expiratory volume in 1 second. And this is considered the minimum clinically important difference that can be perceived by patients. This graph shows those patients, and here you can more clearly see that early drop, although these patients also seem to have a recovery later on in the course of treatment. There was no association between declines in FEV1 and clinical characteristics, including CD4 count, viral load, culture time to positivity, or symptoms as assessed by the COPD assessment tool. We also looked at symptoms, and here you can see a plot of the scores on the COPD assessment tool, where again, patients generally had a decline in symptoms over time, as would be expected. For the COPD assessment tool, a change of more than 2 points is considered clinically significant and perceptible by patients. And so about a third of patients had an initial decline of at least 2 points between baseline and 4 weeks, but about 20% of patients actually had an increase in symptoms during these first 4 weeks. Although interestingly, these patients were not necessarily those that had a drop in their lung function during the same time period. And so in conclusion, changes in pulmonary function among patients starting ART and TB treatment are heterogeneous. About 20% of patients have airflow limitation. About half of patients have a significant decline in lung function with a drop in their FEV1 of at least 100 milliliters in those first 4 weeks. And during the same time, about 20% of patients actually have an increase in their pulmonary symptoms during this time. Long-term follow-up of this cohort is ongoing, which will enable us to determine whether some of these early changes translate into chronic lung impairment. But meanwhile, at this time, risk factors and predictors of COPD and pulmonary morbidity in TB and HIV are not known. And further research is needed to better understand both the epidemiology and the pathogenesis of incident lung injury in people with TB HIV, and whether adjuvant treatments, such as steroids for iris or even lung-directed therapies, might be warranted to prevent lung injury going forward. I'd like to thank my co-investigators who are acknowledged here, as well as generous funding support from the NIH. And with that, I'll close. Thank you.
That was a really nice presentation, really important issue. I have a couple questions. The BMI at baseline was pretty low, it was 19. And so have you taken into account whether was there an impact of BMI either at baseline over time on the respiratory function? That's question one. Question two is, given the improvement in the CAT score, do you anticipate that in your serial follow-up, does that typically improve before the actual function improves? Do you anticipate that well, I guess you're going to look at whether FEV1 improves as the CAT score improves over time. But so my first question was about nutrition. Second question was about your measures.
Yeah, so lung functions are actually standardized to ideal body weight, which is based on height, but certainly nutritional status might factor in. As we start to get more data, we're going to be exploring that in more multivariable models. The question of what's the sort of typical response and whether the COPD assessment tool or others would track with lung function or how they might follow that, it's really an unknown area. I think there's increasing research into lung health in COPD and recognizing that, again, there's potential for long-term morbidity even amongst these people who are otherwise cured. So, we're excited to be gathering these data, and hopefully we'll be putting some of this out to say, how do symptoms actually reflect lung volumes, and what does that mean for the patients themselves, and whether they're going to be dealing with long-term lung damage even after they've been cured.
Hi. Hello. Okay, thanks. It was excellent and interesting, provocative. I'm curious about the 20% that dipped at 4 weeks and whether you know more about them. Were they different in terms of severity of pulmonary disease, lower CD4 counts, and also were there any other manifestations of iris, since that's what the hypothesis is, that they might have had fever or other things that might go along with an iris-type reaction?
Yeah, so we're still looking through a lot of those data. We have some radiographic data to go along with it, along with clinical data that was collected during the patient interviews and serial follow-up visits, and we'll be bringing some of that in. We haven't been able to look at it so much yet, but for those who dropped, the variables that we've looked at, which, whether it be change in CD4 count, change in viral load, baseline bacillary burden, none of those are actually correlating directly with the change in symptoms or with the change in lung function. But we'll see as we gather more data whether some trends seem to emerge, because that would certainly be the hypothesis.
I think we still have perhaps 4 more minutes if there's any more questions from the audience.
Luke Davis, Yale School of Public Health, Yale School of Medicine. Thanks so much, Sarah. Really interesting data, and always excited to learn a little bit more about COPD in these patients. I just wanted to ask you a little bit about smoking prevalence. I know you had it in your slide. I think it went by quickly. And also biomass fuel exposure. I mean, we're increasingly knowing that these types of exposures are important in HIV-infected patients from large cohort studies in other countries, both in terms of COPD and cancer, and maybe we should start thinking about some of those things in our populations in Africa who are now having a longer life expectancy.
Yeah, so the smoking prevalence, the way we've asked is whether they were ever smokers or current smokers. We don't have sort of a pack year value for the ever smokers. So all I can say is that 20% reported ever smoking, but none were current smokers. And then in terms of the biomass fuel exposure, we are collecting that data, and the number was quite low, and I wonder if it's because we're dealing with more of an urban cohort. So I don't have it off the top of my head, but it was quite small.
Thanks again. Looking forward to hearing more.
Thanks.
Given all the LAM discussion we had, so let me make a small plug. The Meet the Expert session in Hall 6 in 15 minutes is going to be looking at whether we need to rethink the role of gene expert in diagnostic algorithms in resource-limited settings in the context of trials showing little benefit and patient outcomes. So if you're interested in that conversation, it'll be in Hall 6 in 15 minutes. Before the room empties entirely, I just want to say thank you to all our speakers for their contributions today. It's been a very interesting session. Thank you to my co-chair, Nicola, and we hope you enjoy the rest of the conference.